Gavin served as a former legislative director to Congressman Alan Mulhan, and has 2 decades of policy experience with the Alliance for Patient Access, where he helps to provide advocates the appropriate level of access for patient care. And he knows a lot more about Medicare Part D than I do. So I've asked him to come and explain this for the very specific point that I have a lot of you who are in that 60+ age range who are trying to manage what options you might want to utilize in terms of managing your HCM. So we wanted to prepare you for what Medicare does and doesn't do. And please remember, the problems that exist within Medicare as a system are not Gavin's fault or mine. It is above our pay grades. So we are trying to work within the system that we have most effectively. Gavin, thank you for joining us today.
Thanks, Lisa. Thanks very much for having me. I appreciate the opportunity. I've got a short PowerPoint, if it's okay, if I could share my screen, and we'll just walk through kind of Medicare
Absolutely.
101.
Perfect.
Let's see if we can do this. Can you see that?
We can.
Perfect. Thank you. And so I'm very pleased to be here today. Thank you so much, Lisa. I'm with the Alliance for Patient Access, which is a nationwide network of healthcare professionals who come together to focus on the patients of patient-centered healthcare. And so we focus on the primacy of the healthcare provider-patient relationship, making sure that they get to make the healthcare decisions that they feel are best for their continued care. We accomplish this mission through educating clinicians on issues impacting patient access and empowering them to engage policymakers. And so Medicare is certainly somewhere where we spend a significant amount of time and energy because it covers so many important issues and so many important people. So we're going to do a little bit of a level set with what is Medicare. Medicare is one of the health insurance programs that we talked about earlier in the program, but it's a federal health insurance program largely for our seniors. So for folks who are 65 years and older are eligible to enroll in Medicare. Certain younger people with disabilities are also eligible to enroll. And then people with end-stage renal disease can also enroll in Medicare. And so this is the healthcare insurance program for our senior citizens. Medicare really has kind of 4 different parts. And so we'll walk through each one of the parts because they're important to understand them. And so what would be considered original Medicare is Medicare Part A and Part B. So Part A is the hospital insurance benefit. So inpatient care, skilled nursing facilities, hospice care, and some home health care is covered through Medicare Part A. Medicare Part B is what we would consider medical insurance. And so this is your doctor services, your outpatient care, medical supplies, and preventative services. And so A and B are what are considered original Medicare. About 20 years ago, Medicare Part D was added to the program. And so this is what we would consider the prescription drug coverage benefit. So this is when you think about a pharmacy benefit, your typical pharmacy benefit. It is separately enrolled from Part A and Part B, and the government encourages individuals who become eligible for Medicare to enroll in Medicare Part D right as they start their Medicare coverage policies. In fact, they have fairly significant financial penalties for people who delay in enrolling in the Medicare Part D coverage. The interesting part about Part D is it's run by the private sector, so this is private healthcare insurance, and you have to pay a premium in order to access that care. As I said, Medicare Part D helps to pay for prescription drugs. And so to obtain this coverage, you must join a Medicare-approved plan that offers drug coverage. There are 2 different ways to get it. There are Medicare Advantage plans, so MA plans, or what would be referred to as Part C plans. These are private sector-run healthcare plans that cover Part A, the hospital, Part B, the medical, and Part D, the pharmacy, all in one coverage. Or you would separately enroll into the Part D program. So once you're enrolled in a Part D program, you have a pharmacy benefit, but it is a little bit more complicated than simply maybe what you might see in a traditional commercial pharmacy benefit. And so there are several phases of coverage that individuals have to pass through as they go through their pharmacy benefit. So the first phase, the opening phase, is a deductible phase. And so the individual enrollee in the Part D program has to pay the entire deductible amount for covered prescriptions up to a certain price point. So the first several $100s come directly from the patient to be paid out through this deductible phase. Once an individual has met their deductible, though, they go into what's called the initial coverage phase. And so this phase here, which runs up to about $4,400 of out-of-pocket expenses, the participant pays 25% of the drug cost. And so these drug costs are negotiated between the insurance provider. There are several different providers of Part D and the manufacturers, but the patient responsibility remains 25% of the drug cost. And then there's a donut hole, which referred to as donut hole, coverage gap. Once the Part D plan and the patient between their co-payments spend roughly $44,430, they go into a gap where the pharmaceutical company, the manufacturer, takes over that gap, and the patient still has some exposure and liability in that phase, but the manufacturer then picks up and pays that other 75% of what the out-of-pocket cost would be. And then finally, unfortunately, some patients go right through the donut hole all the way to the catastrophic coverage phase. So this is when you spent more than $7,000 a year on prescription drugs between all payers. So between the insurance plan, between the manufacturer, and between the individual, the covered individual. Once you get to 7,000, you come into the catastrophic phase. Unfortunately, the patient still has some exposure here, that 5% of their prescription drug costs, but the remainder is picked up by the federal government. And so patients have to work their way through each one of these coverage phases as they go with their medications. And obviously it goes off the cost of the medication. And so it's unpredictable how fast or how quickly or slowly somebody would move through these phases. I talked about Medicare Advantage. Medicare Advantage plans combine A, B, and D together into one plan. They're offered by private companies and approved by the Medicare program. Most of these have pharmacy benefits in them, but they are more limited in other ways. But we just want to flag that there are two different ways that you can get your pharmacy benefit through Medicare. Importantly, each Medicare beneficiary receives an explanation of benefits every month. And so the government will mail them or email them an explanation of their benefits. This is not a bill, and it doesn't explain what things are costing you. But what it does do is tell you what phase you're in of the Part D program, and then what your total out-of-pocket payments to date have been, and then other detailed information about the claims. And this allows people to manage their expectations and know where they are within the process, so that they can help understand and how to cover their their pharmacy benefits and costs. So the Part D out-of-pocket maximums, we talked about this on the early part of the presentation. Commercial insurance all have out-of-pocket maximums. The Part D program does not have an out-of-pocket maximum. And so this is something that people need to be aware of. Even once you've spent this significant amount of money, $7,500, you still have 5% copay of your medication costs that will continue forward. On the other hand, Medicare Advantage plans typically do have an out-of-pocket cap. It may vary by plan, but they do in fact have an out-of-pocket cap. On the Part D program, this is very out of step with any other insurance product that's out there that folks take the benefit of, the no out-of-pocket cap. And this is something that Congress is looking at closely right now and trying to address as they're going through kind of the drug pricing conversation and trying to help individuals. And so in addition to insulin issues, this out-of-pocket cap in Part D is something that they're spending a significant amount of time and energy on. I want to flag one thing that's out there to help folks. So for folks who are income limited, there's the Extra Help Program, or the Medicare Low Income Subsidy Program. About 25% of Medicare beneficiaries qualify for this program, and it gives them extra resources in order to pay for their costs, their Medicare costs. It can be used for premiums, it can be used for deductibles, and it can also be used for co-insurance to cover your medications. And so this is one program that's out there. There are other programs out there to help that I think will be touched on as well in this program. But we wanted to cover, kind of what the benefit looks like, how important it is to enroll in the benefit, but also kind of where the exposure for individuals sits within that program. I'm going to pause there. Here's my email address if folks have questions that they want to ask me at some point in the future. Otherwise, I'll be here with Lisa to try to help answer any questions now. And so if I can unshare my screen.
I can help you with that.
I think I got it.
You got it. Okay, I do want to bring up a CAMZIOS direct issue. If an attendee has a question, I see a hand raised. We're going to need you to use the Q&A box. At the bottom of your Zoom screen, you should see a Q&A option, and you can type your question in there, and you can lower your hand because we will not be opening microphones today. So I do want to bring one other program to everybody's attention, and I'm going to screen share here for a second. So we have been working with the Health Well Foundation for Medicare patients. And this is their website, and they are providing an opportunity for Medicare patients to receive up to a $10,000 award for their prescription to cover their out-of-pocket expenses. You need to be, and this is a pretty high level, 500% of poverty level. So if you are still working at 65, you may not hit this number, but if you are retired or working part-time at this point, this may let you qualify, and you can receive a grant to use that money for premiums or for co-pays or for echoes, anything that is related to your Camzyos prescription. So that is one foundation we are working with. There may be others. If this one doesn't work for you, let us know. We may have a couple of other options coming up in the future as well. So I think what this speaks to is the awareness that there are various access points, and there are a lot of different variables that we all deal with in managing health insurance access. But there have been a number of resources already developed and put in place for the private insurer and the Medicare patients, that there's help there. If you want to try it, you shouldn't be deterred by a financial decision. There are lots of opportunities here. Gavin, we did have some questions. Somehow some of my questions got cleared. Who's clearing my Medicare questions? Unless people withdrew them because you did such a great job of explaining it all. I think
Not possible.
It's possible. I think it's possible. So there were some questions over the echoes, and I know this is not your definitely, you're not a Camzyos expert, but if somebody were to be billed for echoes that were on a label, they're just going to be charged their regular Medicare payments for that part of it, correct?
I believe that would be correct.
Okay, and we've got a cute dog walking in the background. We like
Sorry.
dogs. No, don't apologize. We like dogs. Dogs are good. Okay, so I think that answered that question. I'm going to go a little forward thinking here in the current situation. What changes do you think might come through Medicare? We all know that it's a crisis. We've got to do something. Does there look like there'll be any activity at the federal level to make some of these changes that we so desperately need?
That's a great question. And so I think, as everybody knows, Congress is currently in the process of trying to come through with a drug price negotiation package, funding package. I can't pontificate on whether that's going to be successful or not successful, but I can say that this is the furthest we've seen Congress go towards helping our seniors with a Part D out-of-pocket cap. It's been a conversation for the past 2 or 3 or 4 years of trying to make sure that that program, that pharmacy benefit, gets some certainty for our seniors. And so the current proposal would cap their annual out-of-pocket at $2,000, which is still a significant amount of money, but it's certainly having the ability to plan and know what your out-of-pocket expenses would be a significant improvement for our seniors. And so regardless of what's happening with the other larger policy questions, we've seen significant progress in a recognition that a Part D out-of-pocket cap would be something that Congress should consider, and they certainly are taking it very seriously at this point. So I would like to say we might see that happen for us.
So I would be remiss if the patient advocate in me didn't say, this is a really good time for you to contact your elected officials and explain to them how this might be adversely affecting you. And remember, they're there to work for you. So please use your voice, please use your vote to make sure that the changes that you feel are necessary for you and your family are top of mind for your elected officials. I don't know how else to put that more strongly, but y'all need to get involved and use your voice. So we have, I'm going to send some documents as a follow-up to this webinar on some economic models that can be used to figure out how much it would cost to have drugs that are at higher prices. This is not an inexpensive drug. This drug is in the $89,000 to $90,000 a year range. And that means to somebody on Medicare that could be a very big out-of-pocket expenditure, which is why I would really encourage people to look at the HealthWell Foundation, because that $10,000 grant opportunity may cover your out-of-pocket expenses here. But Gavin, could you explain how, like a very big dollar drug, it would be the first couple months will be a higher deductible and copay, and then it balances off over time to a much lower rate, although still a high, you're talking $300 to $400 a month at the 5% rate. So can you explain what that drop looks like from the highest to the average for the rest of the year?
Yes, I can certainly try. And so you raise a very important point, which is much of this prescription drug benefit is front loaded. The cost of this front loaded. It starts at the beginning of the calendar year. So you return the new calendar year and all that you've paid goes back to zero. And so you immediately have your entire deductible that you must meet. And so if you're paying 25% of the cost of an expensive medication, that first $400 to $440 is going to come directly from you, plus whatever remainder is up to that 25% for that treatment. And then come the second month and the third month, you will be in that same situation until you get towards the coverage gap. And so immediately you're responsible for all of the costs, but then you share that cost, but it's still significant cost until you get to that coverage gap. And then ultimately until you get to that catastrophic. And once you get to that catastrophic, your exposure goes down to 5% per month, but it still can be significant. And so this is something that really needs to be remedied through legislative efforts in order to help either put a flat cap, but also to help a smoothing mechanism so that the cost can be spread out throughout the calendar year. We know that folks will stay on their medications month over month over month. And so it doesn't serve a good purpose to force a large out-of-pocket expense up front, which might deter people from starting or certainly would deter adherence. And so these are policy issues that need to be considered.
It's a huge problem because we know seniors and those on disability ration their own medications inappropriately oftentimes. So we want to make sure that patients don't fall into those situations, and we're trying to set up as many safety nets as possible so that there's some financial support as you go forward with your prescription. Carmen, I hope that answered your question. We've answered that live. Stephen, I'm asking Ross to please drop Gavin's email in the chat box, or one of my staff if they can do that, because I can't copy and paste at the same time. Gavin, is there anything else patients should be thinking about when they're signing up for Medicare, or they are at their election period where they can make changes? Is there an advantage to an Advantage program, or is there a disadvantage to an Advantage program?
That's a great question, and I wouldn't say there's an advantage or a disadvantage. It's really kind of it's tailored to an individual's need. And so one of the flexibilities that comes with Medicare Advantage plans is that they do have flexibility to add in additional benefits that you wouldn't get through the traditional Medicare program. And so they may have vision coverage, or they may have dental coverage where you would not typically get that through. And so that seems to be something that people value and have enticement. On the other hand, though, they're more restrictive in who you can see, what providers you can see, your provider networks. You have more like an HMO model rather than a PPO model. And so, it's a check and balances. I would encourage, folks, and this is very confusing stuff, but I would encourage folks to work with the patient advocacy community and organizations such as yours who can help them understand kind of the nuances of the programs that you're taking. One thing that I will say is if you're going to go through the traditional Medicare route, be very careful about enrolling in Part D at the start. There is a punitive penalty that comes every month that you don't enroll after your initial enrollment period. And I believe it may be a 10% increase in premium per year that you don't enroll, or something along those lines. And so that's one thing that I would flag for folks is make sure that when you're getting your benefits, that you're checking that you're enrolling for the benefits you think you will need long-term, not just the ones that you'll need in the near term.
Fantastic. We just had a really good question here, and I was going to ask this myself. So plan year for Medicare starts when?
January 1?
January 1. So if somebody were going to want to make the most of their Medicare dollars, if they were to start something mid-year, they'd have to pay their copays and deductibles again on January 1.
I believe that's true.
Okay, so you want to be fiscally responsible when you're starting a new medication, when you're planning a surgery, when you're planning a device implant, all of these things, you need to kind of look at your annual calendar for chronic disease management to be financially, aware. And there may be times of the year that are more advantageous than others for certain subgroups to start different therapies or consider different things. So Ross, thank you for asking, I'm sorry, Stuart, thank you for asking that question. That was very helpful. Another question. My experiences with the Advantage plans have not been good. They operate like HMOs and they bar access to specialists. My experience coming from being a health plan administrator back in the day to my role in patient advocacy, I find that PPOs serve our population better and HMOs can often limit access to high volume center of excellence care. So I would tend to lean into an HMO or check in advance that your physicians are covered in a particular Advantage program. And that may be something that we start looking into a little bit more as we approve new centers to come onto the HCMA Recognized Center of Excellence programming. So thank you for that comment, Anonymous. I agree. Okay, so I'm going to thank Gavin for his time today. I've got a couple follow-up slides, and then I'm going to take a second at the end to go into my email, pull Gavin's email, and put it in for everybody for chat, because for whatever reason, only the host can chat with everybody. Sorry about that. So I'll put that in the chat in a moment, and we will be sending a follow-up email with some of these links to all of those who participated. And again, if you have any questions, please contact us. So I wanted to just get rid of that for a moment. Again, remind everybody about the Health Well Foundation. You can find this information on the HCMA website under our CAMZIOS page, as well as some other resources that will be there. I would be remiss if I did not thank our staff behind the scenes and our board of directors, which I spelled wrong because I was in a really big hurry cleaning something up. So they're directors, not directors, for helping us do everything that we do every day.